undergraduate. We are delighted by the enthusiasm and interest shown in this program, and we hope today's sessions will provide you with practical insights that will be valuable throughout your clinical career. To formally begin today's academic proceedings, I would like to invite the project chair, Maharatan Karanayanasan, to introduce our distinguished guest speaker for this morning.
Good morning, guys. So it's a pleasure all of you all with me this morning, and also it's a pleasure inviting sir for this ECG workshop. And introducing and telling about sir, it's actually an honor to say that sir started his journey at our faculty, and then when he finished it, he finished it with the first. He finished it with the all island first in the merit list with multiple medals, and then he started his career as a cardiologist in 1986, and his achievement is so as published. About 90 papers, participated in international trials, and also it's remarkable that Sir was the founder cardiologist of the cardiology unit at the teaching hospital Colombo. So, and it's actually an honor since Sir was the one who actually made the syllabus for the PGIM Institute in Cardiology, and we actually wanted to do this in the 5th floor multipurpose hall where we have given Sir a better venue for the lecture, but unfortunately the pandemic crisis and power rises and there are some hassles, and we are currently doing it here. Sir doesn't mind that. But anyways, it's with pleasure I welcome Dr. Ruvan Ekanayake sir to give his lecture on interpretation of ECG.
Thank you very much. I think the lecture seemed that it was easier for me. But I don't know the audience. Now, I was medical students, secondary, third year, so mixture. Because I don't know at what level to speak to you, but I will introduce the basics of ECG first, and then go on to interpretation, which is clinically relevant. Now, when I come to basics of ECG, I will just give you a bit of history. In 1942, it was an Italian scientist called Carlo Metamucci, who was actually the father of animal electricity. He used to poke electrodes into various parts of the frog and detect electricity, and he detected that the heart also had electrical activity, including the skeletal muscle. Based on this, Einthoven decided that he will record the ECG, the cardiac impulses rather, and then it was he who created the ECG in 1895. So that in 2006, we celebrated the centenary of the ECG. Now it is past the centenary, and it is an extremely valuable clinical tool which has served very well, and he was awarded the Nobel Prize in 1924 for his work. Now this was the first ECG recording made by Einthoven. The patient is seated here. With this, electrodes and various things are not there, but in order to get the electrical current flow into this galvanometer which then records it, this was the compass apparatus that he used. Now, what is the fundamental principle of the ECG? It is that transmembrane ionic are generated by ionic membranes of adjacent cells. Now, when the heart muscles contract and the electrical impulses occur, that electricity is not dissipated through the body fluids. It comes to the surface of the skin. So that the cardiac electricity is found from head to toe, anywhere where there is skin, because through the body tissue fluids, electrical impulses are conducted to the surface. This is the crucial point which Einthoven realized, and this is why we record now the ECG from the skin, because it goes from all areas. So the transmembrane ionic currents are ultimately responsible for potentials and are recorded as ECG. And it is stated that when a current comes towards the electrode, it is the eye looks at the current, coming towards it records it as a deflection, going away from it records it as a negative deflection. Basic physics. And this electrical change is called polarization, and this comes to the surface of the body. So what is the ECG recorder? It is nothing but a galvanometer. The ECG recorder, this is the wall, millivolts. Now millivolts will not create any deflection. So the ECG is a galvanometer which amplifies. It is nothing but a galvanometer and electrical current that comes to the surface. Now how does the heart get electricity? It gets electricity from the pacemakers of the heart. And it comes from the SA node first, because there is spontaneous repolarization, phase 4 of the electrical potential. And this is the dominant pacemaker of 60 to 100 beats at inherent rate. Then we have the AV mode, which is a backup pacemaker, which is an intrinsic rate of 40 to 60. And then we have the Purkinje network cells, the backup pacemaker is of 20 to 40. Now, when the SA node depolarizes and its rate is about 76, it comes down, the AV node and the ventricular cells are depolarized and then rendered null and void. So that the highest pacemaker, which has the highest heart rate, inherent rate, dominates the heart. The lower ones cannot keep up. If the lower ones come, that is irregular, and that means it is like the hierarchy. So rules, if the bottom ones start functioning while the SA node is moving, then it is like a terrorist group for criminals. Whereas the SA node rules and others keep quiet, then it is the sinus wave that comes on. So here is the SA node in the RA, and it comes down in the AV node. There are the internodal pathways, and then down is the conducting tissue, the bundle of this, which divides into two, the left bundle and the right bundle, and then into the Purkinje network. And this is how the goes. So the current is sent into the heart through a circuit, through electrical circuits. It does not go haphazardly, it is methodical. Now to measure the difference in electrical potential, we have two types of leads. The bipolar lead, which will different points in the body, and the unipolar leads, where one point on the body and a virtual reference point with the zero electrical potential located at the center of the heart. Now this is electrophysics. You need not understand this for clinical work, but this we have to tell you as basic sciences. So the ECG that we record with all this has 12 leads. It has 3 standard limb leads, augmented limb leads, and precordial leads. Now we will discuss each of these, because looking at all these 12 leads, you will wonder how on earth am I going to interpret an ECG. Now we will take the limb leads. All limb leads are there from L1, ABL, L1, L2, L3, and then the augmented leads, which is taking a zero potential and no other lead, is a unipotential leads, and which have. Now all these are limb leads. These limb leads are on what is called the vertical plane of the heart. The limb leads from the vertical plane of the heart. Whereas the precordial leads are on the horizontal plane. So when we record an ECG, we record the electrical currents on a frontal plane, on a vertical plane, and on the horizontal plane. Horizontal plane also has 6 leads, V for ventral, V1 to V6, and these are the now a basic introduction to the leads. Now you will wonder, if the current is coming to the surface of the heart, why are we recording only 12 leads? Can't we record it from somewhere else? And yes, we can. In fact, we can record ECGs, say, from all these leads on the chest wall, back and front. So that sometimes we have ECGs where we are about 60 to 65 leads recorded, complexes recorded. But for clinical work, we have selected only 12. That is not arbitrary. By experience, we have selected 12. But it is possible to record from any in the skin. For example, you might get a patient who has no arm or leg amputated or road traffic accident. Arms are missing, legs are missing. Can you record a ECG? Yes, you can. Because you can go to the closest point on the torso and place your lead all onto the stump of the limb, and then the ECG recording will be the same. Because what is there at the left shoulder joint will be the same electrical potential which is there at the left wrist. So this is important to keep in mind. And we record it on a paper. Now to interpret the ECG, you must know the basics of the paper. It is recorded with the squares, and on the one large square is equal to 0.2 seconds with the paper speed of 25 millimeters per second, and on the top the x-axis, that is the millivolts that are coming into the paper. So the paper gives two indications. It gives us the duration and also the electrical strength. Horizontally, one small box is 0.4 milliseconds, that is 40 milliseconds. One large box is 20 seconds, that is 20 milliseconds. So this is important to keep in mind when we calculate the heart. One large box is 0.5 millivolts, therefore 2 boxes, 1 millivolt coming into the heart. Now when you record ECG, you must interpret it, and it is good to keep this great 14 items in your mind. You look for the standardization. This is what you do in your analysis. This is called the systematic analysis of the ECG. You look for the standardization. I will give you some rhythm examples later. You look for the rhythm and you look for the heart rate. You calculate the PR interval. You calculate the QRS interval. You look for the QTC interval. I don't know whether these terms mean anything to you, but these terms you must know. You look for the electrical axis. You look for the configuration of the P-wave, the QRS, and how the R wave changes from lead to lead. This is called the precordial R wave progression. You look for abnormal Q waves, the ST segments, the T waves and U waves. If you look for these 14 points in the ECG analysis, you have got a complete interpretation. Don't get frightened, but it very routine. Sometimes it is easy, and the ECG new machines actually give you most of these machines recordings, calculations on top of it, so that you can just read it off your recording. Now, what is meant by standardization? The first step while recording the ECG is to look for whether the standardization is properly done. What is standardization? Standardization is when a current comes into the ECG machine, it must record the current correctly. So when we do the ECG, we press a button on the ECG machine which sends 1 millivolt into the machine. The machine has a button which you press, sends 1 millivolt into the system so that it records, and the cursor moves, giving rise to. So 1 millivolt must move 2 squares. Here you are. Normal, here 2 large squares. You have pressed the button, standardization button. 1 millivolt has come into the ECG machine. It has gone up 2 squares, indicating that 1 millivolt has crossed 1 centimeter of 2 squares. That is the correct standardization. If we have damped it, then 1 millivolt will cross only 1 square. If there is over damping or under damping, then it goes up higher. Now, this is important when you look for differential hypertrophy or any other hypertrophy, because the complex, if your standardization is not correct and it is under damped, you will get huge complexes. If it is over damped, you will get minute complexes. So when you see over-damped, huge complexes, very tall complexes, or very small, minute complexes, go to the beginning of the ECG paper and see whether your standardization is correct or not. If it is not correct, you cannot interpret. Then the heart rate, we calculate the heart rate. Now its ECG paper is moving at 25 millimeters per second. Therefore, ECG will take 50 bit squares. Each is 20 milliseconds, therefore, or 0.2 seconds, 50 will be 100, which is now there. Multiply that by 10, and then you multiply, that you get in 10 seconds, multiply the 10 seconds by 6 and you get the heart rate. Now this is important to take 50 large squares and calculate when the heart rate is irregular, because when the heart rate is irregular, sometimes it is slow, sometimes it is fast. If you calculate only from the fast area, you get overestimate. Calculate only from the slow areas, you will get an underestimate. Therefore, to get the proper average, it is recommended that you take 50 big squares. Now, the atria depolarized node is there. And then it creates what is called the P-wave. And I will first give you the features of a normal P-wave before I go on to the description of the P-wave production. It is always positively L2 and L1. I will tell you why. It is always negatively lead AVR. And it is less than 3 small squares. It is less than 3 small squares. 1, 2, 1.2.4 or something like that. Very small. Less than 1.2 seconds that is. It is less than 2.2 small squares in amplitude. Here you are. The amplitude is also less. And it's commonly biphasic in V1 and best seen in V2. Best seen in V2, I don't know whether all you are working intensive care with, sometimes we do what is called cardiac monitoring. When we do cardiac monitoring, we need to see the P-wave properly in order to analyze the rhythm. And therefore, all monitoring is generally done in L2 because it shows the best, manifestation of the P-wave. Now, here is the SA node. Here is the SA node in the right atrium. Here is the left atrium. Now the current starts, SA node starts from here and the current comes down. It has to go, no, it is right, SA node is right on top, so it comes down. When it comes down, when you look at these ECG put up, we have now reposed here the frontal plane and the horizontal plane, one on top of the other. Therefore, V1 to V6 only. Now concentrate on the V1 to V6, this circle here. This current is coming down. It is coming down towards V1 and V2. Therefore, in V1 and V2, the P-wave will be upright. Why? The current is coming down towards it. In V1 is looking at this atrium. V1A, this RA complex is coming down, but the LA complex is going away. Therefore, V1 will say, the first part came to me down, the other part is going away from me. Therefore, the P-wave in V1 is generally biphasic. Positive and negative. This is the explanation for the negative, for the biphasic P-wave in V1. Right? V1, V2, V3, both are almost coming the same way, though I have put the arrows that way. Therefore, it is V1 that shows this. Now, if you take the same impulse coming down and you forget this V1 to V6 and look only at AVL, L1, L2, L3, AVF, this black lines which are going, which is the vertical axis. AVF will look at this and say, oh, it is coming down to me. L2 will look at me and say, it is coming down towards me. L1 will also say, both are coming towards me. Therefore, in L1 this will be positive. AVF will say, it is going away from me because part of it is going away. Now, this is the reason why we said the P-wave is generally positive in L1 and L2. It is generally biphasic in V2. Now, what I am trying to tell you is, you must not by heart these patterns. When you know the electrical flow in the heart, you can easily work out how these complexes can be explained. And these explanations are sometimes necessary in complex analysis. Now, here is an example. Now let us take an example where, what shall we say? Let us take an example where here, let us say the right atrium is grossly enlarged. Can you mention a condition where the right atrium is grossly enlarged? Say pulmonary hypertension, pulmonary stenosis, right atrial regurgitation. These conditions, the right atrium is enlarged. Now what will happen? There is a lot of current coming down the right atrium. Therefore, what will happen is that if V1 is looking at it, it will see that the first part is very tall. Current is coming down, the right atrium is enlarged. But the biphasic part is normal because the LA has not enlarged. Now on the other hand, let us suppose that the LA has enlarged. Say common cause mitral stenosis or mitral regurgitation. The LA is enlarged. Now what will the P-wave say? Looking at it, the P-wave here at V1 will say, oh, the RA first component is normal. So normal amounts of current are coming. But a lot of current is going away from me in the LA, and therefore the dip is great. You understood? Now therefore looking at the L2 will say the RA is coming as normal, but L2 is coming as high, and therefore you get this notched wave, which is called the P-mitrale. The P-mitrale, which is the notch. Can you now realize how the notch is being formed? The notch is being formed because the LA, which was usually not marked, is now getting marked and getting superimposed and merged with the RA. So this is how you interpret your P-wave. This is just an example to say basic sciences will tell us how the P-wave behaves. So here we are. Here is a true ECG. You look at L2 for the proper configuration and you find that the P-wave is very tall. Almost as tall as the QRS complex. So you don't get P-waves like that all the time. And then you know that the RA has enlarged. They will say the RA has enlarged. We call it the P pulmonale, but you can call it anything. It is the RA has enlarged. Can you understand? We look at another ECG. We look at here a diagrammatic representation in L2 of the ECG which has the P wave which is notched 5 feet. As I told you, P mitrale, because long ago mitral stenosis was the commonest cause of a P mitrale. Nowadays, your senior cardiology will tell you it is not mitral stenosis that is the commonest cause of a notched P wave. It is diastolic dysfunction. Diastolic is systolic or diastolic? Obviously diastolic. In diastole, the mitral valve is open. In diastole, the mitral valve is open, correct? Yes, because it's filling. Therefore, in diastolic failure where the diastolic pressures are high, it is transmitted to the atrium. It is transmitted to the left atrium. Therefore, the P wave, the current generated in the left atrium is high in diastolic dysfunction. Therefore, in diastolic dysfunction also, you get a P mitrale, and then when the stethoscope says there is no murmur, and you find a P mitrale on the ECG, the clinician says, I must be dealing with diastolic dysfunction. So here we are interpolating cardiac function from the ECG. Understood? It may all be too much, but never mind. Now here I have, this is of course my diagram, say the right atrium and the left atrium. Generally it must be separate, but it does not separate because it comes together and therefore it merges together. Now when it comes together, the merged one is called the algebraic summation. Becomes bifid, and when the tall R comes on, or the tall RA comes on the same RA, then you get a P mitral. This is called merging. Now atrium is reached. Atrium has contracted. Atrium must now, that impulse must come down, diastole has occurred, blood is flowing to the ventricle. Now the current must come to do the other part of its work, which is to cause the ventricle to contract. Now the ventricle can start contracting all at the same time. If it does so, no filling will occur. No filling will occur. You must wait till the ventricle fills for the ventricle contraction to occur. Therefore, the atrial contraction, the atrial tissue, electricity must take a little while to go into the ventricle, and this is what is indicated by the PR interval. There you are. The ECG shows the PR interval. There has to be a PR interval to allow the ventricle to fill. So what happens during the PR interval? The ventricle is filling. Atrial depolarization occurs. There is a delay at the AV junction. AV node and the bundle of his both cause the delay. It is contributing to the PR interval. And the delay allows time for the atria to contract before the ventricles contract. Normal PR interval, 3 to 5 small squares. If you do it for that enough. If it is long more than 1, it is the second degree or first degree heart blocks. So heart blocks. Now remember this term heart block. When you say heart block, we have 3 heart blocks, first degree, second degree, third degree. All heart blocks are at the AV node. All heart blocks are at the AV node. There is no heart block elsewhere. Bundle branch blocks are different. The heart block term indicates all blocks at the AV node. Sometimes the PR interval is long. More than, here you are, long PR interval. P-wave it is less than, more than 5 small squares. You calculate the PR interval from the beginning of the P to the beginning of the keyword, right? From the beginning, not from the end of the P, from the beginning of the P to the beginning of the keyword. That is how the interval is calculated. It is now almost 2 large squares, 10 small squares. So therefore first degree heart block. Now the question will be asked, is there a bradycardia or not? Is there a bradycardia or not? And the answer is there is no bradycardia. That is why, because even though the PR is long, all complexes are conducted down. All complexes are conducted down. As an exercise, go and take it out and see. Can a long PR be associated with the tachycardia? Yes, it can. A long PR can be associated with the tachycardia. If you put the stethoscope, can you detect a long PR? Nowadays, nobody uses the stethoscope to detect a long PR. But in our time, the professor of medicine, Professor Dharmarama, who was a great clinical cardiologist because he did his MRCP in cardiology long years ago at Edinburgh, used to teach the short PR makes the mitral valve comes to close with great velocity because there is no time. So it comes to close with great velocity. Therefore, the first start sound is loud in the short PR. When it comes to the long PR, it is soft. Therefore, if you have veiny back, normal PR, short, normal intensity PR, normal intensity first start sound, second start sound becomes soft, second start sound becomes softer, second start sound disappears. The veiny back phenomenon. Long PR will give rise to a soft PR, a soft first start sound. Now, the ventricle has come to be depolarized. Therefore, the depolarization of the ventricle occurs, and both the right ventricle and the left ventricle both will now depolarize. It is to be separate, but it occurs together, and therefore we get only one QRS complex. Now, if you take the ECG and you wonder, as medical students you always wonder, is the ECG giving us a complete record of the electrical activity? And remember, there is the atria. There are 2 atrias. Once the 2 atrias are there, the right atria must depolarize, the left atria must depolarize. That we have discussed in the P-wave. Now once the atria depolarize, the atria must also repolarize. No? Where is the repolarization wave? The repolarization wave also must be the right atrial repolarization and the left atrial repolarization. And these repolarization waves are not usually seen, they are so tiny. But they cause changes in the PR segment, which only experts will look at. But you don't have to worry about it. But nevertheless, we must tell you that these recordings are also there. Then the ventricle comes, and the right ventricle and the left ventricle also develop, depolarize and give rise to a QRS complex. Both come together on our recording paper. The right ventricle must repolarize and the left ventricle must repolarize, therefore there must be 2 waves. So the ECG which we analyze actually is giving us an incomplete electrical picture of the ECG, of the electrical activity. But behind that, the electrical activity is going on, and therefore all clinicians who interpret these ECGs keep this in mind, and then you can see subtle changes. So this is interesting for you to know that these things are also there. Any suggestions from the audience as to how we can record this? I have been wondering. And then one thing we can do is we can have the ECG going at very, very rapid speeds. We do at 25. We have the ECG machines. They can go up to 50. But if you go up to about 100, you might get it. And to amplify it, if you do it amplification greater than what is the galvanometer does in the ECG machine, you might be able to record this. And this research is also now undergoing. Now the QRS duration. Now we are coming to the QRS thing. It is 2.5 small squares, 80 to 100 milliseconds. That is the duration of the QRS. When you see the pictures, you will understand. And the intrinsic impairment of conduction in either the right or the left bundle causes the prolongation of the QRS power. Now the impulse comes down the bundle of his into the two bundle branches, no? Right bundle and the left bundle. So if the left bundle and the right bundle are conducting all right, the QRS is narrow. If the right bundle or left bundle is blocked or conducts very slow, then the QRS becomes wide. Therefore, we have two types of bundle branch blocks, the complete bundle branch block and this thing, what I don't know whether you need all of this, and we come to the bundle branch blocks. But I am not going to talk about bundle branch blocks in this lecture. I am now going, because you can always read it, I will talk about the left bundle later on. I will tell you something about the electrical axis. I am going through all this very fast because we have another segment to cover, the QRS axis. A lot of medical students and junior doctors get confused about what is called the QRS axis. Now the QRS axis gives us the general conduction direction of that electrical current, and we calculate this QRS axis. We calculate the QRS axis, and it becomes important in our clinical work for ventricular enlargement and conduction blocks. Now the QRS axis, here you are, we record on the precordial, in the vertical plane. The precordial axis is not calculated in clinical work. If you read your Chamberlain, you will see that he calculates also the horizontal plane axis, but we calculate the QRS complex only on the vertical plane. And here you are. If it is minus 30 to minus 90, we say it is normal axis. If it is minus 30 to minus 90, we call it left axis deviation. If it is minus plus 180 to plus 90, we call it right axis deviation. So here, if it is between 180 to 90, it can be extreme left axis or it can be extreme right axis, and therefore we call it indeterminate axis. We call it indeterminate axis, right? So this particular diagram you must keep in mind. Minus 30 to minus plus 90, normal axis. 30 to 90 minus left axis. Right axis deviation is plus 180 to plus 90. Now, how do we calculate? There are ways of calculating it, but we will not go into all. We will just give you one. You have the quadrant approach and the equiphasic approach. We will not talk about the equiphasic. I prefer the quadrant approach. And here we are. Now, here is an ECG. In the quadrant approach to calculating the axis, you take only two complexes. What are the two complexes? L1 and AVF. L1 and AVF. I'll tell you why we take these two. Now look at this ECG. L1 is plus positive or negative? Negative. AVF is positive or negative? Positive. Now we are asked, what is the axis on the vertical plane?
How do we say that? This happens to be right axis deviation. How did we say that? Now, if you take this, now we are talking about where the axis is, no? Take L, I said to take L1, here is L1, and I said take AVF. Those are the two leads at right angles, correct? You take L1 and you take AVF. Those are the two leads that you take. L1 in our ECG was what? Negative. Isn't that so? AVF was positive. Now keep that in mind. Now AVF is positive. Here you are. Positive. Now L1 here is positive. Here is negative. L1 is therefore here. Can you understand? L1 axis is here, AVF is here, and when you draw the coordinate, it is in the right axis deviation quadrant. Have I made myself clear? Yes. Now take another example. L1 is up, AVF is down. L1 is positive, AVF is down. Let us calculate the axis. This is left axis deviation. How did we say that? AVF is negative. Therefore, AVF is here. Because this is plus 90, no? Minus 90 is there. Therefore, it is here. L1 is positive. Therefore, it is here. Here is one axis, one dot. Here is another dot. Where is the axis? Here. Left axis deviation zone. Therefore, of course, you can calculate. If you want to calculate, you calculate this way. You take, for example, L1 may be, say, 2 large squares down, large squares up. If 2 large squares up, then you put 2 marks here. By the same, if AVF is also 2 marks for positive, you put 2 marks here. You join the 2 coordinates and you draw a line and you get the axis in degrees. Now, if it is normal axis, in normal axis, L1 is positive and AVF is also positive. So, in the axis calculation, you take only the L1 and AVF. Don't worry about the other systems of the axis calculation. This, if you keep in mind, it is more than enough. Now, I will give you a basic nomenclature of the QRS complex before I go on to interpretation. The first initial deflection of the QRS. Remember the definition? The first initial deflection of the QRS is called a Q. If it is very small, it is called a simple Q. If it is very large, it is called a where is that? Q. Capital Q. Now the first positive deflection is called a R wave. The first negative deflection is called a S wave. Now let us take this complex. Here, the negative deflection, initial, therefore it is very large, therefore capital Q we agree. There is no positive deflection. Therefore, the first and the last negative deflections are 2 together. Therefore, it is called a QS. Here the R wave is positive, but it is very small. The S wave is small, therefore it is simple R and simple S. The R wave is very tall, therefore it is capital R, but the S wave is small and narrow, it is called a simple S. These are the nomenclatures. If you take this, a Q wave is there, a R is there, and S is there. Here a Q is there, R is there, no S. No Q here, R is there, S is there. No Q, no R, no S, only a R. No R, only Q, and only S, together merged QS. This nomenclature you must know. Therefore, what is pathological is a capital Q, what is pathological is a capital S, and all the others are deemed normal. So this nomenclature is important. So normal QRS complexes, QRST, you all know that from your physiology. I will not bother about it. Now I will now skip all this normal and go on to the final part of this. How shall we go? All these important, but I have no time to go into all because I have some another lecture to do. Now I am going to finish this part of the lecture by giving you 10 rules. These are called Chamberlain's 10 rules of the ECG. Chamberlain's 10 rules of a normal ECG. What is the first rule? First rule deals with the PR interval. The PR interval should be 3 to 5 little squares. So if it is 3 to 5 little squares, the first rule of Chamberlain is fulfilled. It is normal, right? 120 to 200 milliseconds, which is equivalent to 3 to 5 little squares, right? What is Chamberlain's second rule? The width of the QRS, that is from the beginning of the Q to the beginning of the ST segment, the QRS complex, should not exceed 110 milliseconds. That is, it is less than 3 small squares. Beginning of the Q, beginning of the junction of the Q S to the ST, it should be less than 3. Therefore, this is 1, 2, little less than 3, 2 and 2.8 or so small squares, and therefore this QRS width is normal. If the QRS width is more than that, it is a bundle branch block. There is what is called a conduction delay, bundle branch block. So the second rule of Chamberlain deals with that. Now, the third rule of Chamberlain, QRS should be dominantly upright in lead 1 and lead AVF. Dominantly upright. It should be upright. Can anyone tell me why? Because if it is not so, the axis will not be normal. For the normal axis, we needed it come to minus 30 to plus 90, where the L1 is positive and the AVF is also positive. Therefore, Chamberlain's third rule indicates, he does not talk about the QRS axis, but we give the interpretation. Why is the Chamberlain's third rule true? Because then only will the axis be normal. So here's a normal axis. We have done all this, but I will tell you again because this axis confuses a lot of people. Here is L1, here is AVF. If both are positive, then the cardiac axis which is given in negative, in red, becomes in the normal axis range. That is the explanation for the third rule. The fourth rule. The QRS and T waves tend to have the general direction in the limb leads. Now in the limb leads, this in the limb leads, that is in the vertical plane, not on the horizontal plane. The T waves and the QRS are in the same direction. Let us demonstrate that. QRS is positive. T wave is also positive. QRS is positive. The T wave is also positive. Look at this lead. R and S seems what? Equal. It is called equiphasic. The R and the S are equal. What is the T wave? Flat. Now if the QRS was negative, where is the T wave? Inverted. So you look at the inverted T wave and you wonder, is this positive, abnormal or not? You look at the T wave flat and you think, is it going to invert or not? No. Look at the QRS. Chamberlain's rule 4, QRS and T waves tend to have the same general direction in the limb leads. Right. Rule 5. If you take AVR, all waves are negative. There is no exception to the rule. In AVR, Chamberlain says P is negative, QRS is negative, T is negative. All waves are negative. A lot of people get confused about the AVR. They look at the negative T's, negative QS complexes and say pathological. It is not pathological. AVR, all waves are negative. Rule 6. The R wave must grow from V1 to at least V4, must grow. The S wave must grow from V1 to V3 and then disappear in V6. In V6, no S. This is called the progression of the R and the progression of the S. This rule 6, because as it changes, the complexes change, no? As the rotation occurs. So this is important. Remember V4, it is the point at which the transition occurs. It is the point at which the transition, early transition indicates that the left ventricle is hypertrophied. Late transition indicates that the left ventricular muscle is gone. So the transition indicates from rule 6 that occurs at about V4, S waves a little earlier at V3. It must disappear at V6. Rule 7. The ST segment should start isoelectric. This is the ST segment. So let us take the ST segment. Here is the ST. Isoelectric. Now how do you get the ST isoelectric line? You take the isoelectric line. Now have I given this here? No, I have not given it there. The isoelectric line is sometimes very, very difficult because complexes are going down, because the patient has been breathing or has been coughing or the electrodes have been moving. And how to get the isoelectric line, I will tell you sometime later. From PR to PR, you draw a line. Not from ST. Now we are calculating the ST, no? So because we are looking at the ST, you can't take the ST as your guideline. Your parameter must be something else. And we take the PR to PR and we draw the PRs together, and if the ST is up or down, then we know that the ST is there. ST segment should start isoelectric, but then some other deviations can occur. Rule 8. This rule 8, 9 and 10 are all merged together. It says, puts the leads L1, L2, V2 to V6. So this is about 7 leads of your 12 leads are given together in rule 8. They say the P waves should be upright. L1 upright, L2 upright, L3 doubtful, but work it out on my diagram and you will see why. Now when you come to V2 to V6, all P waves are positive. All P waves are positive. Others also can be positive, but in the normal ECG, this is an invariable right. L1 to L2, V2 to V6, the P waves are positive, upright. And here we show why. You see, L1 and L2 is in this direction. Let us give the other diagram. Here you are. We have superimposed L1, L2. Now L1, L2, V2 to V6 are all in the same category. Hello? Oh. 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 Antibiotic ke dunna? Hari. ඊට පස්සේ කියනවා කියලා. Hari. 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 Thank you. Now looking at this diagram, you find that L1, L2, V2 to V6, when you superimpose one on top of the other, are in the same category. Isn't that so? Same class. Therefore, the P wave behaves in the same way in all these leads. Simple as that, if you remember the axis deviation. Rule 9 is on the Q wave. There should be no Q wave or only a small Q less than 0.04 seconds or less than 25% of R wave in width in again V2 to V6, L1 to L2. Therefore, the Q is not pathological. The pathological Q is wide and the pathological Q is deep. The pathological Q wave is wide and the pathological Q wave is deep. Now this rule 4 says a small Q, I said no non-patho, small Q waves, negative diffractions are called simple Q. less than 0.04 seconds, right? That is less than 2 small squares, and less than 25% of the R wave. Now, if this R wave, let us take this R wave. Now we have 5, we have 8, and we have 10. Now, because we have 10 negative deflections here, we have about 10 or 8 negative deflections, positive deflections here, which is the R wave. The Q can be only 1 millimeter or so, 1 or 2 millimeters, because otherwise 25% of this should be the Q, less than that. Now let us take a Q. If there is a Q anywhere here, the AVR you can't take a Q. There is no visible. Here is a Q. There is an initial negative deflection, a Q. Can you see that? But we know it is not pathological. Why? Because it is less than 25% of the height of the R wave. And also it is very, very narrow, less than 0.04 seconds. Therefore, we know this is a non-pathological Q. These are Chamberlain's rules of normal ECG. Again, remember the clustering L1, L2, V2 to V6. Right. Now, the final rule, the T wave must be upright in L1, L2, V2 to V6. So, L1, L2, V2 to V6 all are behaving together. ECG interpretation is very easy. Therefore, the T wave must be upright. And why it is to be upright? The reasons are not going to be discussed here, but you will know that if the P wave is upright, QRS is upright, the T wave also has to be upright, except in AVR where it is negative. Now, sometimes, remember, though we talk about this ECG, what is important is not the ECG. What is important is the patient's clinical history, because the ECG can sometimes deceive you. And I will tell you from basic principles one example where the ECG deceives you, and then go on to the next segment of my lecture if there is time. It appears normal, but is actually abnormal. Of course, there are things where are abnormal, looks abnormal and is abnormal. But I am going to tell you, don't fall into this trap. A patient comes with severe chest pain. He comes with severe chest pain. With the severe breast pain, the blood pressure has come down, he is sweating, he is radiating. All the associated factors of ischemic heart disease are there. And you do the ECG. Here is the ECG. There is a bundle branch block. But looking at these STs, you are not that alarmed, no? Are you alarmed? No. Less than 1 millimeter or so. AVR, STs are elevated, that is true, but we'll forget about that. Looking at the rest of it, it looks normal. Looks fairly normal. It is not normal. And therefore, you must remember, you can't go on the ECG alone, because I will tell you why. This ECG is recording complexes at the same time from the heart, various different positions. And in the heart, what happens is what is called an algebraic summation. That is, when the ECG lead is placed, currents come towards it and currents go away from it. Say a current comes towards it from a certain muscle area, which is 10 millivolts. Let us say at the same time the right ventricle is also depolarized and a current is going away from the electrode, 2 millivolts. Now the ECG electrode will record only +8 minus 2. Understood? The algebraic summation is what is the ECG recording. The algebraic summation. If the ECG electrode is looking at a muscle area, say +4 is coming towards it and +4 is going away from it, the ECG summation will say there is no current coming to it and it will be a flat line. There is no exact summation, so therefore you get a minor thing, but it is very minor. Now in that particular patient, here is they do a coronary angiogram because the history is suggestive, and left main, and there is a critical left main occlusion. critical left main occlusion. Now, when there is a critical left main occlusion, it is not only the left anterior descending, but also the circumflex which gets affected. Not only the left, all branches are affected no, at the left main. Therefore, at this trifurcation, the left axis, the left main disease causes LAD obstruction plus ischemia in the circumflex territory. Therefore, the septum is also affected and the posterior wall is also affected. When you look at this part, the ST elevation is there. You put the eye here, the ST depression elevation is there. But if you look only from this area, this elevation and this depression gives a reciprocal effect, and here the ST segment depression comes down. Therefore, you look at the ECG and say, there is nothing much of ST changes. This has happened even with a doctor at the LRH. ECG is repeatedly done normal, but the history was such. Therefore, whatever investigation that we do is an investigation. Remember, never forget the patient's clinical profile. Right. Now, basics of ECG I have now finished. I will not go to the second part of my lecture if there is time. Is there time? Can you put the second part? Second part I will finish very quickly and finish. What is the time now? 10:30. 1 hour, no? Now I am going to do part 2. I am going to talk about myocardial infarction, because you all are not interested in the electrophysiology, no? You all are interested in getting a diagnosis correct. I am going to talk about a myocardial infarction. Now, we have myocardial infarctions and myocardial infarctions, ST segment elevations, non-ST segment elevation, never mind. Now, these are some examples. ST segment, oh dear. ST segment elevation, myocardial infarction. ST segment elevation, yes, ST segment elevation. There is ischemia, ST segment depression. And there is ischemia, T-wave invasion in non-STEMI. Non-ST elevation, ST elevation, and these are non-ST elevation, acute coronary syndromes. All these three are called acute coronary syndromes. All these three together are called acute coronary syndromes. ST elevation myocardial infarction, ST depression acute coronary syndrome, T inversion non-ST elevation myocardial infarction. Now I am going to talk about the ST elevation myocardial infarction pattern. Here you are. You have three components in the myocardial infarction. You have a negative initial deflection, therefore this will be a capital Q. You have the ST segment going up, and then you will have the T wave coming down. Now I want to tell you how these three segments of the ECG are produced, the electrophysiological interpretation. We need to correlate the pathology and the ECG changes to answer this question. So what is the pathology? The major coronary arteries are all epicardial. That is, all coronary arteries are on top of the heart, surface of the heart. Only the branches, only the minute capillaries penetrate into the muscle. All are on top of the heart. Why? If it is inside the muscle, when the heart goes into systole, the arteries will get squeezed and the blood supply will stop. Therefore, the Creator has put the coronary arteries on the surface, so that when the muscle contracts, the coronary arteries do not get compressed. That is the reason why. The blood supply to the myocardium comes from the epicardial region to the endocardial region. I will show you a diagram. Therefore, the endocardial region gets the greatest insult of coronary occlusions. Right. Here you are. Right coronary artery is there. The left coronary artery is there. And these are on top of the heart. Now, if there is a block in the coronary artery, like this, what will happen? Now, in this, I have put a star here. The coronary artery CA is here, located here. Understood? It is located here on top of the heart, in the epicardial surface. Now when this is blocked, this part will get a little bit of blood, let us say. This will get little more than that it lost. When it comes deeper, there is almost no blood supply. Is that correct? Is what I am saying rational? So when you have an epicardial artery which is blocked, and that epicardial artery block causes ischemia, the myocardium said to be divided into 3 zones. The zone which is furthest away from the epicardial artery undergoes necrosis, ischemic necrosis, which is called infarction, dead tissue. The part in between gets injured. It does not die, it is still living. Part is dead, part is living, but it is injured. It doesn't function properly. The part very close to the epicardial artery is ischemic, but it is not dead nor is it injured. But it is working at a low oxygen supply. Therefore, you have 3 I's. I infarction, I in the injury, and I in the ischemia. All are ischemia, but the descriptions are given so that you have 3 I's. Infarction, beyond hope of recovery. Beyond hope of recovery, it is dead. Only the good Lord can make dead tissue living again. We cannot. Therefore, what is dead is dead. Injured, we can do something. Ischemic, good, we can do something. Therefore, when it comes to the injured myocardium and the ischemic myocardium, we say it is salvageable. Salvageable means muscle can be recovered. It is living. The infarction area is non-salvageable. Now, how do we differentiate these 3 on the ECG? Now, the ECG, the zone of infarction is given by the Q wave. The zone of injury is given by the ST segment elevation, and the zone of ischemia is given by the T wave inversion. So, here is the deep part which is dead, necrosis. Here we are, dark purple, Q wave. Light purple, injured, ST elevation, zone of injury. Light pink, only ischemia, no injury, no necrosis, zone of ischemia. Understood? Therefore, when you look at the QRS complex of a myocardial infarction, you have it at the back of your mind the pathophysiology that is going on in the patient's body. The width and the depth of the Q wave indicates the extent of the infarction, dead tissue. It is more than 1 millimeter wide, 2 millimeters deep. There is no benefit in revascularization of dead tissue. That is why those long ago we used to divide myocardial infarction into Q wave infarction and non-Q infarction. No point. What is the use of saying Q wave infarction? That is dead. Therefore, we will no longer use that term. We will say ST elevation myocardial infarction or ST depression, non-ST elevation myocardial. If it is ST elevation, then there is injured and salvageable myocardial, you can do something. So here is a Q wave. This is a simple Q, again a simple Q, to differentiate the Q waves on a ECG. The height of ST elevation indicates the area of injury, still viable. Hence the ST elevation is used to decide on the use of revascularization. Here you are, STs are elevated. STs are elevated. STs elevated. STs are trying to go up. STs trying to go up but not gone up very much. STs trying to go up. If you look at this ECG and you want to interpret it, you will say Q waves and QS in V1. In the V1 segment, depiction of the myocardium, that area is infarcted and finished. V2, V3, V4, it is now getting injured and fully injured. Nevertheless, there is a small R, and therefore it is not a big Q. Part of it knows no doubt a Q infarction is there, but the injured salvageable myocardium is there. In the V5 segment and the V6 segments, the occlusion is still going on, injury is in the process of going on. Right? Now, will this patient have chest pain or not? Remember, dead tissue has no pain. Only living tissue will give pain. Therefore, if you have only Q waves, the patient will say, I am feeling better. You can't say, I am very happy about that. You have allowed him to go into infarction. Whereas if the patient says, I am still having chest pain, you must act. Because there is salvageable myocardium going on. So here we are. Again, the ST elevation is there and the ST depression is there. Now the ST depression can be what is called reciprocal ST. Why you get a reciprocal ST we can't discuss here, but you can get it. Dr. Chandika Pennamberma, one of our very eminent cardiologists, once told me at a lecture, a call is coming from the private sector intensive care unit. Sir, the patient has come with severe chest pain. His ECG shows deep ST segment depressions, but I can also see reciprocal ST elevation in the other leads. Now that won't do. It is the ST segment elevation that is given the prominence. You can't go and talk about reciprocal ST elevations. ST elevation is ST elevation. ST depression can be reciprocal. So here we have. Can you detect anything else here? Yes, you can. The T wave here is inverted. That is AVR. Therefore, it is normal. The T wave is inverted. Therefore, ischemia. Now, here what has happened to the T wave? The T wave is very tall. Very, very tall T wave. The ST is going up and it is merging with a tall T wave. If you read your textbooks, this will come as hyperacute myocardial infarction. The ST goes up, pulling the T wave with it. And therefore, the T wave becomes extremely tall. The T wave changes indicate the degree of ischemia. First to appear, and there is complex recovery. First to appear is the T wave inversion. And this is the evolution changes in a myocardial infarction. At 0 hours, very small Q wave. Infarction is negligible. Injury is there. But the ischemic zone, the T wave, is being pulled up by the ST elevation. And this is hyperacute. You must be very, very aware of this. Now the ST is curved up and some people say this must be pericarditis. Nothing doing. If the pain is severe, if the history is myocardial infarction, ischemia, it is ischemia and hyperacute infarction. Now the STs become flat and the Ts begin to form. Now the Q waves are gradually increasing in size. You have not acted. Therefore, the infarction zone is going up. When the STs start coming down, the T wave has now a chance to go down to indicate ischemia because the ST is no longer pulling it up. But the Q waves are getting deeper. Ischemic zone manifested more and more when the STs are going down, but the Q is getting larger. Q has got larger, established, and the ischemic zone has disappeared. At 1 year, 6 weeks, this is what happens. This is the evolution of the ECG. At this point, the patient will have pain. At this point, the patient will have pain. Sometimes the ST segment elevation is there without pain. Nevertheless, it is ST segment elevation. But if it is there, it is additional feature to say that there is salvageable myocardium. I have to emphasize, you must think this fellow is repeating things all too much. I am repeating because it is important. If the patient is having chest pain, the investigation is secondary importance. It only guides. At this stage, he will say, I have no chest pain. I have no chest pain. I am feeling very good. He may be feeling good, but you have not done your job. The pathological basis of the ST segment ECG explains why we use ST segment elevation to decide on therapy. We need to differentiate viable tissue from non-viable tissue on the ECG. The same thing I have given again. How is the Q wave produced? I think I am going too long, no? You all want to know how the Q wave is produced. We know why the Q wave is being produced. It is called the window. You can tell me when to stop. But sometimes we start, we go on and on. Now here the electrode is there. Here is the electrode. And here is the left ventricle. Now, this is the left ventricular wall, and this is the left ventricular wall here. Right? Now it has two walls, no? Interventricular septum. Now both are depolarization. Now this is having an electrical impulse because the Purkinje network is somewhere here. The current is going this way, this way, this way, this way. That is the normal way the current flows. Now let us say that this part has got infarcted. This part has got infarcted. You put the electrode here. When you put the electrode here, what do you see? This part is electrically inactive. Therefore, you see the interventricular septum. This electrode sees the interventricular septum through the infarcted area because the infarcted area is electrically neutral, electrically inactive. It is a window. And then it sees that the current is flowing away from it and it draws a Q wave. If this part is only very small, only a small Q wave. If this part is very large, all the septal infarctions, depolarizations will be recorded with a large Q wave. So this is called the window theory of the Q wave. The electrical inactive period allows you to look at the other part on the other side and gives rise to this thing. Right. Now the normal, we won't talk about that. This is all window theory. Why does the ST segment go up? The ST segment goes up because, you see, once the heart depolarizes, the heart must repolarize, no? The ischemic segment does not repolarize properly. Therefore, in the infarcted heart, you get a depolarized section and an incomplete repolarized section, and between these two electrical potential occurs. And there is a current starts to flow between these two. The depolarized area which is normal and the incompletely repolarized area which is abnormal, the current path is called the current of injury. And because of this current of injury, the ST segment goes up because a new action potential occurs. Here we are, the action potential, you know all this action potential, how the action potential is there. In the normal myocardial thing, the potential difference is there. In the systemic current of injury, it is there. If you see the action potential in phase 2, in the plateau phase, the ST segment is neutral. But if the current starts to flow even in plateau phase, then the ST segment starts to go up. Right. Shall we stop there? Or you want me to tell the left bundle branch? We will stop, we do very quickly and finish off. I will talk about left bundle branch block. But I want to talk about what is called the summation. Now you have learned that the left bundle branch is called M-shaped. Isn't that so? M-shaped here, M-shaped in V1. Can you see the notching? Have you ever wondered why you get a notching? I will give the simple explanation. It is because, here is another one, incomplete. It is because the ventricle has two components. The right ventricle and the left ventricle. The right ventricle and the left ventricle usually are two together. When there is a bundle branch block, the two separate out because in the left bundle branch block, it is coming later. And because of that, you get a summation of a R dip and R prime, the white QRS, and this is why the M shape is produced. It is produced because the bundle branch block, so also the right bundle, it causes a delay separating out the QRS complexes of the right ventricle and the left ventricle. And when you do cardiac resynchronization therapy, the width of the QRS becomes very important. Now we will not go into the rabbit ears. I will come to the P mitral. We have done the P mitral and we are given the T wave. After I give this, I have finished. T wave in T wave. This was important. So the T wave comes at the phase 3 of your action potential. Now the heart has undergone depolarization and the QRS complex has occurred which is upright. Now the heart has undergone depolarization and is producing a T wave. That T wave must be upright or downward. Any suggestions? Any suggestions? If depolarization caused upright, repolarization must cause a negative wave. But it does not happen. It does not happen. On Chamberlain's rules, it did not happen. That is because even though the depolarization occurs from, now these are the questions medical students must ask as clinical scientists. No. Depolarization occurred from the endocardium towards the epicardium. Correct? Because the Purkinje network is endocardial. Therefore, the current flows in this direction and the QRS is upright. Now, if depolarization occurs from here to here, from here endocardium to epicardium, then the T wave must be inverted. But in the human heart, the repolarization occurs from epicardium to endocardium in a direction opposite to the depolarization. Now, when electrophysiologists looked at the ECG and they started interpreting, they wondered why is the QRS complex positive and the T wave also positive? It can't be. One is depolarization, other is repolarization. Therefore, they put in the microelectrodes and they detected that the repolarization is going in the other way, other direction. It starts at the area where depolarization is last and comes to the area where the depolarization is first. This is necessary in physiology in order to keep the ventricle tensed up to squeeze the blood out. Otherwise, you will not get the blood squeezed out. If this part relaxes, once this part is kept tensed up, then the blood inside the heart can be expelled with greater efficiency. We will not talk about this. Now, you must remember this term ischemic cascade. When there is cascade, the first thing that happens is metabolic changes, perfusion changes come, cellular changes occur, and the first thing that we can detect is diastolic dysfunction, even before chest pain. Even before chest pain. In the ischemic cascade, diastolic dysfunction comes first, the systolic dysfunction comes second, then only the ECG changes come with the chest pain. And then we have all the ischemic syndromes coming. So remember, when the ischemic cascade is taken into account, the echo is sometimes very much earlier, and the point of care echo study, that is called at the bedside, point of care, becomes extremely important. I will give the T wave morphology and then I will stop. This will be my last slide. Here is the T wave upright. Here is a T wave which is biphasic. Here is a B wave which is notched. Here is a P wave which is broad and slow. Here is a P wave which is again rather flat. Now these P waves are called non-specific ST wave abnormalities. These cannot be discarded. They can be normal with hyperventilation, etc., full stomachs, hiatus hernias, electrolyte imbalances. These T waves can occur. It can also occur with ischemia. They can also occur with also these bifid notch T waves and the biphasic T waves in what is called the repolarization milieu. Repolarization milieu means this is the area where the repolarization occurs and the environment of the repolarization is depicted by the repolarization milieu. In the analysis of sodium arrays, these speakers sometimes what are called the sudden cardiac death syndromes. The sudden cardiac death syndromes where they get multiple ventricular arrhythmias and this torsades de Pontes arrhythmias and they can die. Therefore, don't disregard this, say normal. You have to investigate this and say this normal or not. What is pathological of the T wave in ischemia is this T wave, which is called a symmetrical T wave inversion. Symmetrical T wave inversions are pathological. The downward and the upward strokes are equal with a sharp nadir. The tip of the T wave is sharp. This is the feature of a pathological T wave inversion. Symmetrical with a sharp nadir. When the ST is also going down, it is strained. and there is a repolarization variant where the T wave is tall, where the ST has gone up. But remember this T wave. It is a very tall T wave. Very tall T wave. First diagnosis is hyperkalemia. Hyperkalemia. Dangerous hyperkalemia, more than 7 milliequivalents per millimoles, where the cardiac arrest can occur, depicted on the ECG as very high tall T waves. But it is also normal phenomenon in the Sri Lankan population, in the colored Caucasians. It can be normal. Not so in the British whites. When you have a severe chest pain, the first ECG change that occurs, I said, is in the epicardial region, and therefore a tall T is what is the first manifestation. In the hyperacute stage, this tall T is associated with the ST going up, and it pulls the T wave up, giving rise to the hyper ST. So remember the T wave morphology, very, very confusing, but remember only the deep ischemia, the tall T waves, and the bifid waves. There are some more ECGs, but we will stop there because it's almost 11. Now I will not stay to answer questions because are there any SRs here? They are doing the discussion. Who is doing the discussion? So if I hope it was not too much for all. But I wanted to go on what is called basic sciences to explain that by hearting ECG patterns is not what we need. What we need is to understand what is happening.
So thank you, sir, and thank you all for listening. And of course, sir's lecture, I think, has turned the trend and made us understand ECGs rather than memorizing them. And as a token of appreciation, I invite Nuha, the president of University of Colombo Clinical Society, to give a token of appreciation to sir.
Okay guys, to avoid any more delays, if we could all go into our respective groups. So clockwise, we have already arranged the tables, A, B, C, D, E and F. If you all could take your chairs right now and go to the respective groups, that would be great. Yeah.